that. Here we go. All right, so without further ado, we're gonna head into the case. So for those of you who haven't attended a virtual rounds before, welcome. First, we're gonna go through a case, a physical exam, we're gonna build a differential, and then we're gonna spend a lot of the time talking about the pathology of disease. In this case, that's gonna be kind of approaching EKGs as the disease, so to speak. Are you able to access the quiz for today? Yes, awesome, thanks guys. So again, please actively participate if you can. I think that that's how you'll get the most out of it. And feel free to fill the SOAP note out as we go. So I like to do a quick review of this for those of you who were here last week or those of you who have been with me before. I just like to do a quick overview of what the SOAP note is, just to make sure that it's clarified for everyone. So just to be clear, subjective, what does it mean? What will go in the subjective part of our SOAP note? Symptoms, exactly, Adrika. So subjective means anything that's coming directly from the patient's mouth. They're going to tell you the HPI stands for history of present illness. Adam, you're right, family history would also go in there. So anything they're telling you, they're saying my stomach hurts, they're saying my shoulder's been hurting for a week and it only gets better when I rest or when I take Advil. That kind of thing would go in subjective. And review of systems would be my stomach hurts and my shoulder hurts and I feel like I've had a fever. Now, objective differs from that. How does objective differ from subjective? Vitals. Good job, Cole. So exactly, these are kind of objective, indisputable facts about the patient. So they say, I feel like I have a fever, that's subjective, but then I take their temperature and it's 98.6. So they have a subjective fever, but their vital signs, which would go in objective, is within normal limits. And so if they say my belly hurts, that's subjective, but then I press on their abdomen and there's no tenderness on exam would be objective, but you would still document that the patient states that their stomach is hurting. I hope that makes sense. Additionally, any labs or imaging will also go in objective because those are things that are happening, things that we can kind of see and clarify. And then we'll build our assessment and plan together. Typically, that's where we'll list all of the things about the patient that we want to address, and then we'll kind of address those things one by one. I hope that makes sense to everyone. If I'm going too fast, tell me to slow down. If I'm going too slow, tell me to speed up. I want the session to be for you guys. So here are our case details. We have Mr. Jones here. This is a stock photo. He looks pretty unhappy, and that's not me. But this is Mr. Jones. He is a 67-year-old male. He is presenting to the emergency room with chest pain. It started while he was walking up the stairs with groceries. He's had chest pain intermittently before for over the past 6 months, but it usually resolves with rest. This time he's coming in because his pain was severe, sharp, and he had some shortness of breath and nausea. He has a history of smoking for 40 years and recently started trying to work out more and lose weight. So these things will go into your subjective. We have a couple qualifying things here. I'll just chat a little while you guys type. So we like to qualify the type of pain. It's kind of tricky if they're not coming in with pain to qualify it, but typically we like to say where it is, on a scale of 1 to 10, how severe is it? Does it radiate anywhere? So this nausea, is the nausea his chief complaint? What would his chief complaint be? Chest pain. Good job. Exactly. And so what would we call shortness of breath and nausea then? Subject, yeah, exactly. So they definitely go in subjective. We call those associated symptoms because it's not his chief complaint, but it's kind of associated with his chief complaint. So we'll put those there under associated symptoms. We'll also put these in the review of systems. So we would say positive for shortness of breath, positive for nausea. And then if we had asked him, like, do you also feel like you have a fever? Then we would say like negative for fever. And so on and so forth. So then where would the smoking history go in the subjective? Does anyone know? History. Yep, that will definitely go in the history. We call this usually social history, where we'll put like drugs, alcohol, smoking, and things like that for social history. I'm going to move on, but if anyone at the end needs me to circle back to any of these slides so that they can submit their note, let me know. Where's my text? Questions to consider. So now that we know that about Mr. Jones, what kind of questions would you guys want to ask him? He's your patient. You guys are emergency room doctors. History of heart disease is a great question. Personally, he doesn't have any history of heart disease that he knows of. He's never been diagnosed formally with anything, but that's a great question because that would increase his risk significantly. And as far as his family history, I have all of this on the slide. I'm just trying to answer as if I'm Mr. Jones. History of blood pressure, yeah, I think he does have a bit of high blood pressure. He's got some hypertension. He doesn't manage his medications very well, though. Anything else we want to know about the pain itself? Does it feel like his heart skips a beat? Adrika, this is a great question. Do you want to elaborate on why you're asking about the heart skipping a beat or the sharp pain? Maybe what your thought process is, why you're thinking that? Because those are great questions to ask. We call that, sometimes we call these palpitations, but sometimes patients don't know what palpitations mean. So it's nice to kind of put it into layman's terms as you did, which is perfect. So we might ask about palpitations. Sharp pain can be a number of things. Most concerning would be like pericarditis. Exactly, Adrika. So a murmur. Andrew was asking if the pain radiates, which is an amazing question. I'm betting that you guys are kind of starting to build suspicion in your mind. So where classically would you suspect the pain might be radiating? Seema is asking how long the pain lasts. So typically the pain decreases with rest, but this episode that he has now hasn't gone away even though he sat down, which is why he decided to come to the emergency room. And so this pain has been going on for maybe almost an hour. He's not sure. Does his chest feel like it's caving in? Yeah, so definitely want to ask about the quality of the pain. Does it feel like a horse is sitting on your chest? Is it tearing? Is it crushing? Is it just kind of tight? We'd love to qualify the pain, and ruling out an aortic dissection is huge. For those of you who don't know, aortic dissection is when the aorta, which is the large artery that comes out of the heart and supplies blood to the body, basically the wall kind of tears. So you can imagine how devastating that injury could be. Spreading to the upper chest area, yeah, we want to know if it radiates. Maybe GERD pain will kind of stay in the chest. Heart attack pain might go up to the jaw or down the left arm. These are all great questions, guys. So anything specific we might want to look for on physical exam for this patient? We like to do focused physical exams. We don't need to do like a full head to toe skin exam on every patient or something like that. So what type of physical exam would you want to do? What things do you want to notice? Listen to the heart. Sure, definitely want to listen to the heart. See if, as someone had mentioned, if it's skipping beats. Does the heart sound distant? Does it sound really loud? Yeah, Adam, we want to check the skin color to see, remembering that people who have variations of skin color pallor may not present in the same way. So someone who has a darker complexion may not look pale, but we still need to examine and kind of try to look for other signs of pallor for sure. Yeah, because we're checking if he's oxygenated, and someone who's has a less dark complexion, they may look even a little blue around the fingers or around the mouth. Jugular vein distension is a great one, Seema. So we want to see the jugular veins, for those of you who don't know, are up in the neck. If the heart's not pumping appropriately, then blood can basically back up in those big veins that kind of drain the blood from the brain, and they can become distended. And that's a sign to us that the heart's not pumping appropriately. So that's a great, great sign to look for. You guys are doing amazing. And do you have any tests that you'd like to order? We're always trying to think ahead. This patient's coming in with chest pain, which is pretty emergent. EKG, I would love an EKG. That would be great. Yeah, chest X-ray, especially if you work in the ED, you're gonna get a chest X-ray on pretty much everyone, even if they don't need it. We might do a stress test. If he's in this much distress right now, we may not want to put him on a treadmill necessarily, but I like your thought process, because absolutely stress tests are meant to kind of We might have actually liked to put him on a stress test back when he was having the pain that resolved with rest, because then we could maybe induce the chest pain and actually see maybe where the pain is or what's happening in his heart when he's exerting himself. Seema saying troponin, D-dimer, CBC, BNP. So we always pretty much get a CBC, which is going to be like hemoglobin. Is he anemic? BNP is a sign. If it's elevated, typically that will mean that they're in like a heart failure type picture. So we might like to see that. We'd usually like to get electrolytes as well. D-dimer tells us if he's clotting, that's a great sign for like deep venous thrombosis or a pulmonary embolus, which is a big clot blocking blood flow to the lungs. And troponin is a protein that is inside cardiac muscle cells. So when those cells die and they apoptose, they let that protein out, and then that's a sign to us that the heart muscle is dying. So we'd love to see that. And Joshua says an echo. I like the idea of maybe getting an echo. Maybe it's not the first thing we do, but certainly if we hear a murmur, then we'd like to see how the heart is beating. You guys are doing great, amazing. So here is his medical history. He has diabetes. He was diagnosed like 20 years ago. Dyslipidemia. What does dyslipidemia mean? Anyone? Lipid levels are off. Yeah, pretty much. So exactly. Yep. So dyslipidemia just basically means his lipids, usually his cholesterol, is kind of poorly controlled. So usually that means it's high. So he's got dyslipidemia, or sometimes we call this hyperlipidemia, and that just means high cholesterol, basically. Hypertension, meaning he's got high blood pressure, as we mentioned before. And he had a hernia at the age of 28. This just means that the hiatus is kind of right by where the esophagus goes down, passes the diaphragm, which sits below the lungs, and goes into the stomach. So sometimes the stomach can kind of like protrude up through the diaphragm, and it can cause a hiatal hernia. Those things can sometimes cause GERD-like symptoms, which can mimic chest pain. So that's why that's important to know. Perhaps poorly compliant with his medication. So while he may be on, metformin or lisinopril or something for hypertension, he's not taking his meds. So he's not doing a very good job. His mom had an MI at the age of 65. His father is obese and also diabetic, and he smoked for 20 years. Does anyone know what pack years means? This is a bonus question. This is a very tricky question that I didn't learn until mid school. So this is them. I'm not trying to be number of cigarettes smoked per day times. Yeah, exactly. Well done, Seema. Yeah, so it's the number of packs usually smoked per year, not the number of cigarettes themselves, but exactly right. So 20 pack years could either mean he smoked 1 pack a day for 20 years, which would be 1 times 20. But also if he smoked 2 packs a day for 10 years, that would be 2 times 10 is 20, and that would still be 20 pack years. The most I've seen is like, I think someone had like a 500 pack year smoking history. It doesn't mean that they're 500 years old, but it means that they were smoking like an inordinate amount of cigarette packs a day. So it's kind of our way of quantifying how much nicotine is going into your lungs. So that's terrifying, but don't smoke. Works as a bus driver, but retired this year. So he's got a job where he sits a lot. So that's that. So here's his exam. He's sitting up. He looks a little happier now because he's getting treated. So he's sitting up. He's in mild distress. Is this a normal heart rate? No, it's a little fast, right? The upper limit is usually about 100. So 60 to 100 is normal. It's a little fast. Is his blood pressure fine? He's hypertensive. That's correct. So it should be, we like 120 over 80 is a good blood pressure. We know he's got a history of hypertension, so this is poorly controlled. He's breathing kind of quickly. We'd like this to be closer to 16. His temperature is pretty much fine, and he's not saturating oxygen very well, even though he's got a nasal cannula in. 2 liters on nasal cannula. Which is just the little tube with the 2 little nostril bits that go in, and then you tuck them behind your ears, for those who don't know. So we listen to his heart. He's got a normal rhythm. no murmurs, rubs, or gallops, and a non-displaced PMI. So there's a lot of words here, and these are words that you're going to see on most of your patients' charts. So murmurs, does anyone know what it means to have a murmur? What does that imply? Problem with the blood flow. Yeah, exactly. So I talked about this a little bit last week, but so there are two types of ways that fluid can flow. It can flow laminarly, which is just basically straight lines of fluid. Valve function, you're right, Adam, exactly. Or we can have turbulent flow, which is kind of like when that laminar flow interacts with something and causes little turbulence. So if the valves, which is where the blood is continuously flowing through these chambers and through the valves to get into each chamber, if those valves are not opening properly, if they're not closing properly, if they've got vegetations on them, then this is when we see murmurs. So murmurs mean abnormal flow, typically due to some type of valvular function. So both of you guys are absolutely right. Rubs is scary. Rub is the heart sits in a sac called the pericardium in the chest. And if that pericardium becomes kind of angry and inflamed and like sandpaper, as the heart is beating within that sac, it can rub against that inflamed pericardium and cause almost like a scratching sound. So that's a rub, which is pretty scary. And a gallop, usually that means the heart's kind of not got a regular rhythm. We're kind of hearing extra sounds other than our typical lub-dub. Now, our PMI is our point of maximal impulse. So if you feel on your own chest, right around your fifth rib space, which should be kind of in the middle of your rib cage, you should be able to feel go down straight from the middle of your left clavicle to about the middle of your rib cage, and you should feel kind of where your heart is beating most hard. That's called the point of maximal impulse. It should be right at kind of the tip of the heart because the heart sits kind of forward, leaning forward in the chest. So that point on him is kind of is not displaced to the left. If that point was displaced to the left, what would you think that would imply about his heart? Enlarged, exactly. So that would mean that he might have like a hypertrophic kind of disease where his heart had become large. So he doesn't have that, thank goodness. And his valves seem to be pretty much okay. His lungs are clear, meaning he's got no wheezes, rales, or rhonchi. I'm not going to go into that. We're not doing a lung lecture. But wheezes is usually COPD, asthma type picture. What's a normal respiratory? About 16 is usually normal. Rales and rhonchi is like if you listen to a lung, especially like we've heard a lot of this now with COVID, it's kind of a crackly sound in the lungs. So none of that. His lungs are pretty much fine. And he's got no pedal edema. This is a tricky question. Does anyone know why I'm looking at his legs and looking if he's swelling in his legs? DVT? Yeah, that's a good one. So DVT can cause, usually it's only on one side, but that can cause calf swelling, which is a huge thing to look for. So absolutely, we want to look for DVT signs or deep venous thrombosis signs. So that would be one kind of angry red calf usually. You mentioned before, or someone mentioned before in here about the jugular venous distension, which was the heart's not pumping appropriately, blood is backing up into the venous system. So if the heart's not pumping properly and blood is kind of backing up everywhere, gravity pulls down. So if I'm not pumping appropriately, I'm not moving blood, there's going to be a lot of kind of stagnant blood that's going to end up down in the legs and feet. So you might see older people walking around with compression socks, those kind of like big, thick, kind of flesh-colored socks that go up to the knees. That's usually because they've got some type of heart issue. Their blood isn't pumping appropriately. So we're kind of squeezing their leg from the outside to kind of help that blood go back up, fight gravity, and get back to the heart. You know, usually it is. It can be caused by a couple other things, but we do typically see pedal edema. Pedal meaning feet and lower legs. We see that a lot of times in congestive heart failure. That's correct. We call it decompensated because the body's kind of not able to, I don't want to say use it in the definite, it's not able to pump appropriately in its kind of disease state. So yes, is the short answer. Sorry, I'm so long-winded. So anyway, now we got the imaging. Someone hits a chest X-ray, we're going to do it. So here's the chest X-ray. Someone also had mentioned troponin earlier, and I definitely wanted troponins on him. It's high. His white blood cells, they're high. Does anyone want to make a comment about this chest X-ray? I'm no radiologist, and I'm not expecting you to be either, but hung low. The heart seems to be fine. We want the heart to be less than half of the width. I'm not sure if you can see my mouse. We want it to be less than half the width of the chest. So it's a little big actually, but it's not too big. I think the heart's at about the right space. How about the lungs? Is this how a lung should normally look? This is a hard question if you haven't seen chest x-rays before, but just looks kind of foggy. I agree. So this is kind of a congested looking lung. We'd like it to be more black. We'd like it to be filled with just air. So there's kind of something backing up here. Heart's not pumping appropriately. Mr. Jones is still feeling pretty sick, maybe even looking worse. So his chest x-ray doesn't look great. He's got some bilateral infiltrates. Troponin is high. White blood cells are high. This is probably just because his body is stressed out. It doesn't necessarily mean infection, although high white blood cells can mean infection. So I wouldn't get too thrown off by this. And then all of his other values were fine. Here's his EKG, and we are going to go through this. And hopefully by the end of this talk, you'll have a better sense of how to make sense of all these lines. But basically, here's his EKG. We're going to come back to it at the end of the talk, and I hope that this will all make a little more sense, but here it is for now. So tell me now, what would be on your differential diagnosis for this patient? What would be on your differential, guys? Based on everything we've seen and heard from Mr. Jones. Could be an infection. It could, because his white blood cells were high. So could potentially be an infection. White blood cells can be high for a number of reasons, but definitely something good to keep on the differential. Could even be an MI. Yeah, I would say MI is pretty high on the list. He's got a lot of risk factors. Does anyone want to name some of the risk factors he has? His cardiac muscle is dying. Exactly, Adam. So the fact that his troponins were high is pretty suggestive of maybe heart stuff. And as you're mentioning, high BP, risk factor, he smokes, his age, he's got the diabetes, he had high lipids. So he's got almost every risk factor in the book for some type of disease of the vessels. Keeping a lot of other things in mind too, though. So these are the things that I had on my differential. I had an MI, pericarditis is what I mentioned before. The pericardium, again, is that sac that the heart sits in. That sac itself might have become inflamed. And angina just kind of means exertional chest pain, which can cause, you can get an MI if he had exertional angina before and now he's got an MI. Yeah, exactly. We probably would have heard a rub with pericarditis. He would probably look a little different. Pericarditis, I can do a talk on pericarditis in the future. It would look a little different, but you're right. This physical exam doesn't really suggest it. So here is our assessment and plan for him. I'm going to give you a hint. One of your quiz questions is asking about this kind of stuff. So if you want to look ahead, I wouldn't fault you for it. So on arrival, here's how we approach someone with a Stemi. So basically they can get the EKG in the EMS vehicle. They're going to start him on oxygen probably because they're going to be like, this guy looks like he's probably having a heart attack. And we would rather assume he's having a heart attack and then find out later that he doesn't rather than mismanage him. So they're going to start him on oxygen, which he was already on oxygen when he arrived. We're going to give him sublingual, meaning under the tongue, nitroglycerin to dilate his veins, to kind of open everything up. We're going to give him morphine because it's painful to have a heart attack. It's painful for your cardiac muscle to be dying. So we're going to give him morphine, and we'll probably give him aspirin too. Aspirin can help discourage blood from continuing to clot, and it can help a little bit with pain, but we're not mostly the morphine's going to help with the pain. We're going to continuously monitor him on EKG for 24 hours, even after he's already been addressed. We're going to keep taking troponin values. Why is it important to get more than one troponin value, even after the fact, even after he's been treated? Yeah, exactly. We want to see improvement, and we want to see if it's working. And we even want to see if maybe he gets another MI. Sometimes after you stent them, we're going to take him to the cath lab, and we're going to stent open his vessel. If we stent open the vessel, sometimes those stents can clot. Sometimes stenting can move a clot into another vessel. So we want to make sure that he doesn't have another MI, right? And we want to make sure, as you guys are saying, that he is getting better. And then, of course, other things we want to adjust in his assessment and plan. Mr. Jones is not the healthiest man we've ever seen. We want to talk to him about his smoking. Obviously not right now. He just had a heart attack. It's not the time to like shame him for smoking. But we open the conversation. We say, like, if it's something you want to talk about in the future, please. We want to talk to him about his diet. He mentioned he's been trying to get to the gym more to lose weight. So if he wants help with that, we could talk about it. Probably low salt, low fat would be good for him. Medication reconciliation is important to do always. We want to make sure that he is not taking too many medications, that he's able to get his medications. This man is going to need to be on, baby aspirin. This man might need to be on some other drugs to kind of discourage more clots from forming. So we want to make sure that he's good with all of that, and we don't just send him home. And we want to talk to him about his diabetes. He is a diabetic. Lots of different complications can happen because you have diabetes that's poorly managed. So we want to make sure that he kind of understands his disease and is able to treat that as well. So although he's here for a heart attack, we also want to kind of address these other things too. So now we're going to talk about MI, and then we're going to get into the fun stuff. So first of all, what is an MI? It's a plaque. We're saying atherosclerotic, which is why his hyperlipidemia was so important. He's got high lipids, and those lipids can kind of form a plaque in our vessels. And if they form a plaque in the vessels, then blood can't flow. So we'll get a thrombosis, and we can in the vessels, and then that will cause poor blood flow to the heart. So as you can see here, this is our main culprit right here in the front. We call this the left anterior descending because it's on the left side of the heart. This is the left side of the chest. It's on the anterior side or the front side of the heart, and it descends. This is also called the widowmaker. You might have heard it called that colloquially. And that's because it's the most common vessel to clot. So this guy, if we form a clot here, then we would put the stent here to kind of try to open up this vessel, because if not, all this muscle down here is going to die. And that would be what's blowing up and sending out troponins. So now we start to talk about the fun stuff. Why do we get an EKG? Why is an EKG what we use to talk about the heart? So in order for us to understand EKGs, we have to talk about the conduction system of the heart. So the heart has, it's a big pump, but it's also a big electrical being. So the signal starts up here at this node, the SA node, or sinoatrial node, because these are the atria. So the signal will start here. It will come down on either side of these atria. It will stop here at the AV node, or the atrioventricular node in between. And then it will come down to here, to each of these two chambers, and it will, as the signal goes, imagine shocking someone, they will contract. As the signal goes down the ventricles, that will cause those chambers to both pump up. And as they squeeze up, they're going to squeeze blood out to the lungs and out to the body. So that's the basic conduction system of the heart. So as you can imagine, the heart, the energy vector is kind of coming from here. It's coming down into the left. So we have this thing called the QRS complex. There's a couple different letters here. There's P, QRS, basically, and T are the ones that you need to know, P, QRS, and T. So the QRS complex is the biggest complex. That's usually when you see an EKG, you think of this big spike. The big spike is going to be the biggest part of what's happening in the heart, which is when the heart muscle really contracts. And we care the most about this bottom part contracting. So this Q wave, don't get confused if you don't see it on every EKG. You can impress your friends. If you have a Q wave on, which is this little, it's QRS down here. So this is Q. If you have a Q wave, that means that you've had an MI in the past. So not everyone has a Q wave. I don't think I have a Q wave most recently that I've checked. I hope not. So this is not always there. Don't be confused if it's not. We still call it the QRS complex, even if there's no Q wave, but just don't get confused. So this is the big bump, is basically the bottom of the chamber contracting. Now, what directly precedes the QRS is we have P, like I mentioned. So that's, remember, because the signal comes from up here, the signal comes down the atria. So that's this. That's the atria contracting. It's this little bump. And then it pauses for a second as it travels down to the AV node. And then it surges down each of the ventricles, and it causes the ventricles to boom, contract. And then because it sent a signal, now it kind of has to reset. So then this is kind of the ventricle trying to reset so it's able to contract again. And remember, as this squeezes, we're sending blood simultaneously out into either lung and out into the body. So this is basically how an EKG works. The reason that we're seeing the waves go up and down is, again, because basically if we're an EKG, we're a camera. We are a camera down here at the left foot, basically looking up at the heart from the foot. So as I'm seeing these waves come down towards me from the top of the atria, I'm going to see those vectors be positive as they're coming up towards me this way. And then as they're coming around this way, they're going to look a little negative because they're kind of now moving away from me to get back to the AV node. Then they pause. That's the flat line. Then they go up, boom, and that's them coming down here. It's surging down the ventricles, which is this big up because it's a positive vector coming towards me. I'm at the foot, and then it goes big negative. Whoops, because it's going to squeeze up away from me, and it's squeezing away from me is a negative vector. I know this is kind of confusing. This is why a lot of people don't like cardiology, because it's a bunch of messy vectors. So this is what I was trying to say. As an EKG, we're basically lead 2 most of the time. So remember how that EKG had a bunch of different lines. We focus mostly on this one. We're mostly lead 2 because this gives us the straightest shot from the SA node down the heart. Now you're going to see a bunch of other leads, and each of these leads you can think of as a camera, taking a picture of the heart from different angles. I like to think of us as at lead 2 most of the time. I think it makes the most sense. But if you focus on any of the leads of the heart, when we're taking an EKG, you could do the same thing. If it's coming towards me, if I'm this camera and I'm looking at lead 3 now, and the vector is coming down, then it's going to be kind of positive, but not as positive as if I was here, because it's coming towards me, but also a little bit away from me. So it's going to be probably a steep peak or a less tall peak. I hope that makes sense. It's a little confusing. So that's kind of basically the bare bones of what each of the little peaks mean. Stop me if you have questions. Now we're going to talk about how we can use the EKG to calculate rate. So you can do some mathy stuff, but I'm not very strong in math, so I use a cheat method. And the cheat method is you count the big boxes. So you can see that there are thick lines and there are thin lines. And if you count the top of the R peak, which is the steepest peak, because remember it was Q down, R up, and then S. If we count from R to R, from peak to peak, from each QRS complex to the next, and you count one box between each of them, so it's QRS, and then there's another QRS right here. The beats is 300 per minute. If there are 2 big boxes between them, then it's 150 per minute. So remember that a normal rate is between 160. So how many boxes would we normally like to see between RR in the RR interval? Anywhere from 4 to 5. Yeah, usually we'd like it to be somewhere between here and here. Exactly. So that's my cheat method that I use: 300, 150, 100, 75, 60, 50. And if it's slower than that, you are in trouble because that's really slow. So we'd like it to be somewhere in here. And that's the cheat method. So again, like I said, the issue with this and why we're even talking about EKGs in the first place, and why an EKG is used to diagnose STEMIs is because, oh, STEMI, by the way, does anyone know what STEMI stands for? ST elevated MI, exactly. So we talked about the QRS complex, that's our S, and then the T is that little bump that comes right after the QRS complex. So that's where the ventricles are kind of resetting themselves to get ready again to contract. So if that segment is physically up, it's elevated, then that's a STEMI. So what happens is, as this heart muscle, as the signal is coming down the heart muscle here, what's going to happen to this dead tissue? How do we feel like the conduction system is going to be if the tissue that's being basically sent an electric signal to contract, how is it going to contract? Well, poorly, about the same. Poorly, yeah, it's going to contract pretty poorly. So it's not, if we're getting no blood to the muscle will die, and then the muscle will not contract. So we're not going to be seeing our normal, which is why we're not going to see our normal QRS complexes. So this is what an ST elevation looks like. Again, we have the Q. So this guy's had an MI before. Q, R, S, T. So this is our S here, and our ST segment is up. So this means that he's acutely injured. We sometimes call these tombstones because they look a little like tombstones, and it's quite morbid, but also people sometimes die from MIs. So ST elevation looks like this. And if he has just ischemia, meaning that the blood is not really flowing well, but it's not completely blocked. Like, remember, Mr. Jones said he was having some exertional chest pain for a while. It was hurting when he went upstairs, but when he sat down and rested, he felt a little better. So if it's inverted, then that means that he's not getting really great blood flow, but it's not completely blocked. It's not an MI yet. So now we're going to go back again to Mr. Jones's EKG. So let's do a quick exercise. Does anyone want to estimate for me about what his rate is? It's most helpful to try to find a Q or try to find an R that's close to like a big box line. So I might pick like this one and look at this R, and then I count 1, 2, 3, 4. So Andrew says 75. Let's check. 300, 150, 100, 75. Yes, exactly. I would agree with you. So that's how we use a 300 box method. It's going to be about 75. So his rate is pretty much fine. He's not tachycardic. Now, let's see what else we see. This patient has some Q waves, so his heart's not doing super hot. Now, we talked about ST elevations. Does anyone want to take a gander at which leads? These are V's, by the way, not U's. If anybody wants to take a gander at which of the leads are showing ST elevations. 2. Let's look. Maybe a little here. It's not super high. It's not super high, but yeah, it could be a little bit. 5 and 6, maybe a little bit. 3, let's look. So, okay, so 3 is interesting. So we have a downward Q. This is not necessarily bad. Remember that the leads are all cameras looking at the heart from different angles. So I like the way that you guys are critically thinking about this. These ST segments look like they're a little bit above the baseline here. Cole says 2, 3, and 4. I have to agree with that. So I would even say 1 as well. When we see, remember we called these tombstones, it kind of looks like it goes right from this Q complex, it goes all the way up and forms a huge peak here. So I would call it probably V1, 2, 3, and 4, I would probably say safely are my big ones. 5, a tiny bit. It's a little up, but it's not too awful. I would say that the main ischemia is probably somewhere between V1, 2, 3, and 4 is probably the biggest ones. Does that make sense, guys? Do we see that? Yes, awesome. So I understand what you mean. I've definitely done that before too, but I've been yelled at by one too many cardiologists about thinking I see MIs where I don't. But this is a little up, I would say. This is a little up, this is a little up, but these are our main offenders. It's this big, big peak here. Great job. So again, like we said, because each of these leads corresponds to a different anatomic region of the heart, we are already kind of thinking that, sorry, let me collect my thoughts. So since each of the different leads is a camera looking at the heart from a different angle, depending on which leads have a high, have ST segment elevations, we can already start to kind of think about which vessel is occluded, because each vessel that supplies the heart muscle supplies a different territory. So based on that, and based on what we had just said about his heart, does anyone want to take a guess at which artery is occluded in Mr. Jones? Or which region? Coronary artery. Yes, so it's definitely one of the heart arteries. LAD and distal LAD. I would absolutely agree with you, Seema. So we said it was like 1, 2, 3, and 4 were our main guys. So this guy's got, this is 1 and 2 is enteroseptal, meaning that's kind of right in the front, in the middle of the heart. Enteroapical means even further down the front of the heart. So we're saying that this is a huge MI, right? Because this covers all the entire supply of the LAD basically, or that left anterior descending, also known as the widowmaker. So this is a huge artery, the most common to clot. So the pattern that we just saw here, pattern that we just saw here on Mr. Jones's EKG is pretty much the most common EKG that we would see in a heart attack patient. So that's the one that he's got, but depending on if other leads had a little elevation, then that can point to other things as well. I remember that 5 and 6 looked a tiny bit high, so that's also still left anterior descending. So it's just a massive LAD lead. So what we would do for him is we would take him to the cath lab and we would put a stent. We would come up the leg and we're going to come in through here. And then we're going to put a stent in here to open this up. And that's called coronary reperfusion therapy. And that will help to open up the vessel. Now we have a time limit on when we can do this. If too much time has passed, then we can't, it's much harder to go and stent them because they're having a lot of tissue death, a lot of clotting. So sometimes we just give them oral drugs to kind of break up the clot. And if he had clots in some of these bigger areas like here, that we call this a left main, because this is the LAD here, remember? So this is what his heart looked like, basically. It clotted here, and then this whole LAD was dead. So if it had been up here in the left main, because this is the circumflex and this is the anterior descending, we might have even had to do what's called a CABG, or a coronary artery bypass grafting, which is an open heart surgery. Sometimes we have to do those if we can't open it up with a stent, or if he's got like massive multi-vessel disease, and we actually have to take a vessel either from the chest wall or from the leg, and we have to kind of create we would have to basically attach one end of the vein here and one end like down here past the clot, so that blood can go around the clot and perfuse the rest of this muscle. It's pretty cool. I've seen a few. They're great surgeries if you want to stand for 6 hours. They're awesome. So that's what we would do if he was really refractory to treatment. And then we're just going to kind of watch him. He's going to stay in the hospital. We're going to keep him on fluids, and we're going to trend his troponins and keep him on an EKG after his heart attack. So I rushed through that because I got excited. And so we ended a little early. I know that that was a ton of material. So I'm gonna hang around. I'll go back. I can re-explain. I'll answer any questions that you guys have about anything, about hearts, med school, whatever. Cardiac impulse is called action potential. Yes, usually they are. So we have two different action potentials in the heart, actually, just to make matters even more confusing. We have the action potential for the pacemaker cells, which are, let me see if I can go back here. Oh, this is where my sources were. This is the best EKG book out there. It's called Dubin. And then please do the quiz. So where's my thing? Okay. So these pacemaker cells have their own action potentials that are slightly different than the action potentials of the rest of the cells. But yes, that is usually what they are called on the cellular level. There's a number of different channels that all have to kind of work together. There's sodium channels, potassium channels, and calcium channels, and they all kind of open at specific times to let in and out the ions. That allows for the potential to depolarize and then repolarize. It allows those cells to contract appropriately. I think it's pretty similar, yeah. To be honest with you, I'm not a big neuro person, but I do think that they're pretty much the same thing. It's going to be different channels, and their threshold potentials that they need to reach in order to conduct are going to be slightly different. But it's the same premise that they have to kind of depolarize to allow like signal to pass down the neuron and not. But a lot of these, that's why one of the most important things to be managing in patients in the hospital is we have to check their electrolytes. We have to make sure that their sodium and especially their potassium is within the very tight range that we want their potassium to be in, because if it's too high or too low, then the heart muscle, which greatly depends upon signals being able to conduct to allow the muscle to contract and relax. If potassium concentration is too high or too low, then that can cause the muscle to kind of freak out and be like, whoa, there's too much potassium outside. And then the muscle, it will kind of fibrillate, and that can cause a lot of fatal arrhythmias. So keeping people, especially people with like kidney diseases or people who can't regulate their electrolytes very well, keeping them and supplementing them with potassium or diuresing them so that they don't have too much potassium is super important, because especially for someone like Mr. Jones, who's got, who just suffered from a heart attack, we don't want to send him into a fatal arrhythmia because we haven't been managing his electrolytes. So that's another important thing to keep in mind. I'm giving another talk next week about valvular disease. So if you want to learn more about valves, and we talked a little bit about laminar flow, I hope to see some of you guys there next week. I think it's going to be a lot of fun. We'll talk a little bit about heart anatomy and about how all of the ways that valves can get messed up. Me too. I love cardiotox too. It's the only subject I really enjoy talking about. Not neuro, I'm sorry. I'm not here to answer your neuro questions, unfortunately. I only know as much as I've been taught in class. But thank you guys so much for coming and for your participation. I really appreciate it. But I'll hang out for the rest of the time if you guys have any questions about, med school. I'm also one of the editors for Motivate MD. So if you have questions about any of that stuff, I'm here for that too. Bye. See you guys next time.